Thank you for joining us for Unite Precise webinar about health communications and social marketing. We are thrilled to have all of you with us here today. We have over almost 500 participants on this webinar today. My name is Jennifer Staples-Clark, and I'm founder and Chief Executive Officer of Unite Precise. I will briefly introduce you to Unite Precise, then we will review the webinar logistics, and then we will hear from our 4 expert panelists. Unite Precise is a global health nonprofit organization that promotes high-quality care for all. We offer extensive global health and social entrepreneurship education programs. Our Global Health University program offers a free webinar series, including today's webinar. We also offer 20 online certificate programs for students and professionals. Many students receive academic credit for completion of our certificates, and professionals also often pursue a certificate for professional development purposes. These certificate topics range from a certificate in cultural competency to a certificate in global health and a certificate in global health research, as well as 17 other certificate programs. We have additional upcoming webinars during October and beyond, and we encourage you to register for these free upcoming webinars at uniteprecise.org/webinars. In October, we currently have confirmed 2 webinars, one on October 11th regarding environmental justice, and another on October 27th regarding paths to fulfilling global health careers. Additional educational opportunities for students and professionals include participation in Unite Precise annual Global Health and Social Entrepreneurship events, which focus on responsible global engagement. Our 14th annual Global Health and Innovation Conference, which is the world's largest global health and social entrepreneurship conference, will be on April 22nd and 23rd of 2017 at Yale University. This conference includes more than 300 speakers and more than 1,000 participants for a weekend exchange of ideas across all disciplines of global health, international development, social entrepreneurship, including many speakers and participants who are involved with health communications and social marketing. The conference website and registration can be seen at uniteprecise.org/conference. And the abstract submission deadline is upcoming Friday, September 30th for the upcoming 2017 conference in April. We additionally have an annual Social Entrepreneurship Institute, which is also located in New Haven, Connecticut, and the 4th annual Social Entrepreneurship Institute will be on December 2nd, 2016 at the Schubert Theater in New Haven. We additionally have healthcare delivery programs that provide care to patients living in extreme poverty. And Unite Precise partners with local iconics in Ghana, Honduras, and India to provide care for patients who are otherwise unable to access or afford care. These programs are locally led and managed by local medical professionals, and our collaboration has provided eye care to more than 2 million people by local doctors during the past decade, including more than 95,000 site restoring surgeries by the local ophthalmologist. Unite Precise is the world's only organization that is both a healthcare delivery organization that also offers immersive global health education and social entrepreneurship opportunities for students and professionals. Participants support and learn from the incredible local doctors in Ghana, Honduras, and India, as those doctors provide care to patients living in poverty in villages, homes, and refugee camps. So participants then have the opportunity to learn from the local medical professionals about patient barriers to care and about effective strategies to reach the hardest to reach patients who are otherwise unable to afford or access the care. And the local doctors are incredible social entrepreneurs who design effective and innovative strategies to eliminate patient barriers to care. Now I will describe the basic logistics of this webinar. We are so delighted to have all of you with us here today, and we have 4 incredible panelists, and they have a wealth of expertise to share with you during this next hour. Each of our panelists will start by giving a 2-minute introduction about themselves, their current role, and their key guidance and lessons learned regarding health communication and social marketing. Then we will dedicate the remaining time to your questions and answers, and we received stellar questions already from you, our audience, by Monday's question submission deadline. We selected the most common, most thoughtful questions to ask our panelists. We also invite you to submit additional questions today in the text box on the left of your webinar screen, and then we will select those questions to ask the panelists today as well. We also encourage you to tweet about the webinar, including your key lessons learned by using the hashtag GHUWebinar, And you can see that hashtag on the webinar vision screen. So now we'll proceed with having our panelists introduce themselves in alphabetical order. I'm delighted to introduce you to our first panelist, Robert Bazell. Robert, please begin by introducing yourself, your background and current role, and please share your key guidance about health communication and social marketing.
Thank you, Jennifer. I began my career at training as a scientist a long, long time ago. I had an opportunity to go to Science Magazine, where I was one of the founding members of the news section. And then I worked for a newspaper for a few years covering fires and murders, learned about journalism. I was offered a job at NBC, which was a fantastic job. For 38 years, I covered science and medicine throughout the United States and around the world. I was one of the first TV reporters to report on what became known as HIV/AIDS. It didn't have a name then, and I covered more than 45 years for NBC. So from the standpoint of being and I've written many magazine articles and a book, and so done a lot of stuff in print as well as broadcast and on the internet. So I've had a lot of experience as a journalist, and now I'm teaching at Yale, where I do several things. I teach undergraduates. I teach students in the School of Public Health in public health communications. And I guess my main lesson is I learned that the kind of communications that I did as a reporter are very different from what people in public health tried to do, although, of course, I interacted with them a lot from the other side. But it's much more difficult, I think, to do it, to try to bring behavior change, especially to respond to crises, when you're on that side of the aisle as opposed to when you're a reporter seeking information. But I've been also running a program here at Yale where we train young scientists, postdocs, and graduate students to try to present their work in a more effective way, to try to not use jargon, and to be as effective and as short as possible and to understand their audience. So I'll end it with that, and thank you very much.
Terrific. Thank you so much, Bob. And Charlotte Cole, please introduce yourself as well and also share your key guidance and lessons learned.
Thanks so much, Jennifer. It's really a great pleasure to be here today. I'm the Executive Director of Blue Butterfly Collaborative. We're an organization that I co-founded that supports children's media producers in low-income countries. We help them to catalyze and create high-quality children's media to promote education, health, and peace-building aims. My background, I've been working in children's media for over 2 decades. For much of my career, I headed Sesame Workshop's Global Education Division, where I oversaw all of the company's international co-productions of Sesame Street and other international programs. We developed a lot of different kinds of programs using Muppet and other characters. Some of you may know, for example, one of the innovations, which was Cammy, who's a Muppet who is HIV positive. Cammy appeared on Takalani Sesame in Africa, which is the South African adaptation of Sesame Street. And I think she did much to help kids learn about HIV and AIDS and to help break the culture of silence around HIV and AIDS. I'm now carrying this work forward with Blue Butterfly Collaborative, but instead of Sesame Street, we help local teams develop their own children's media properties. And we have projects in different places of the world, Haiti, Ethiopia, and some other places, Sierra Leone. My doctorate is in developmental psychology, and I bring to my work a kind of lens of curriculum development and research. And I think perhaps for that reason, my biggest advice around when developing health communications and in media is to really make sure you invest in research while developing any health communication. It's really important to know first what your target audience knows and doesn't know about a given health concern, and it's also important to test that messaging and content as you're developing it to make sure that people are comprehending it, and to make sure that it's also appealing and fun as you're developing it. And when you test as you create, you really learn a lot that ultimately makes whatever the campaign is more successful. So I think that's my biggest advice. So I guess I'll end there. But thanks so much for including me in this webinar. It's just a delight to be here.
Wonderful. Thank you so much, Charlotte. And Firdaus, Kharas, please introduce yourself and share your key lessons learned as well.
Thanks very much. It's a pleasure to join all of you. I'm the chairman and founder of a media production company called Chocolate Mousse Media. We specialize in what I call media to better the human condition. If you go to my website, you'll see some of our work, and if you go to my Vimeo channel, you'll be able to both watch and download any of my animated shorts. There are approximately 3,500 animated shorts in 169 different language versions at the moment. To the best of my knowledge, my work has been seen in over 150 countries and by over 1 billion viewers. Most of the work is on human rights and on health and disease prevention like Ebola, HIV/AIDS, and malaria prevention, diabetes, dementia, vitamin A, on the environment and on universal values, on education, on governance, on migration, a lot of work on violence against children, rape, other forms of sexual violence, and so on. You can go to the Vimeo channel after this call and download and start using any of my work. It's free of charge. In terms of my background, I was born in India. I'm a U.S. educated. I traveled the world, been to over 140 countries through my work. After graduating from university, I started my own company for a while, then worked as executive director of the United Nations Association in Canada, then worked for the Canadian Cabinet on refugee affairs, then headed something called the Backlog Division of the Immigration and Refugee Board, where we cleared a huge backlog of refugee claimants in Canada. And then I started this media company. The media company I started in 1995, so I've been doing it for 21 years. It's a hybrid social enterprise making for-profit series and not-for-profit media campaigns. And I literally work around the world. My advice is fairly simple. I think that we are now in an age of innovation and technology, which is changing our way of thinking and of doing. So 21 years ago, when I started my work in using mass communications to better human condition, the world was only able to receive information passively through television and radio. And we're now at a new point of human history, which has opened up endless opportunities for all of us, an age of global, instant, widespread, personal, two-way communications. So I would urge everybody on the call to think about how they can engage in this new age of interpersonal, two-way, instant communications. Thank you.
Great. Thank you so much. And our final panelist, Susan Krenn, please introduce yourself and share your key lessons learned as well.
Thanks, Jennifer, and great to be here with everybody. My name is Susan Krenn. I'm the Executive Director at the Center for Communication Programs here in Baltimore. And our center is based in the Department of Health, Behavior, and Society at the Johns Hopkins Bloomberg School of Public Health. As a center, we work in many low-resource settings on a variety of health issues, including HIV, Ebola, maternal health, family planning, and malaria, among others. We also invest heavily in our programming in capacity strengthening in countries around the agenda of health communication. In terms of my background, I've been involved in health communication for over 30 years now, supporting work in a variety of countries and over many health areas. I lived in Nigeria for 3 years in the early 90s, managing a very large-scale family planning communication campaign. And in fact, I entered the field of health communication from a family planning and reproductive health perspective. I've been with the center since 1985 and count myself very fortunate to have landed in the right place at the right time, and this was when the field of health communication itself was developing. So I was very lucky and fortunate to be able to learn a lot of what I've learned on the job. I think my greatest advice actually echoes some of what's been said in terms of designing, developing, supporting programs. Really important to do the homework and do the research to make sure you really understand what you're trying to accomplish, what the needs of the audience are, et cetera. I would also echo the need for the programming to really resonate and be relevant. Otherwise, it's not going to take. And to echo the last speaker, I think, this idea of engagement, it's so important. How do you pull the group into your ideas? How do they take those ideas, digest them, change them, morph them, add to them? That's really, really important. And to have fun. People enjoy having a good time. And how can we use health communication programs not only to attain our objectives of improving health, well-being, whatever our agenda is, but how do we engage people and let them have fun at the same time?
Terrific. Thank you so much, Susan, and thank you to all of our panelists. As you heard, they have a wealth of expertise and guidance to share with you today. Now we will proceed with the question and answer session. As mentioned previously, we received questions in advance from you, our audience members. And if you have additional questions, please post them in the text box on the left of your webinar screen. Our first question is for Bob. Bob, what are some of the most effective communication programs and or strategies that you have seen?
Excuse me, I was on mute. Successful communication programs it depends on whether you're defining it, because everybody is talking here about the standard things that we hear in health communications, which is to understand your audience and to have realistic expectations about what you're trying to achieve. And also if you look at the history, for instance, of anti-smoking campaigns, it takes a long time to even understand what you're up against, because in the United States, starting and now, of course, spreading throughout the world, the tobacco companies had set a template for disrupting and destroying science that we are all dealing with today. And I think a lot of times people can be very naive about all the parts that they're dealing with. So I'm not talking about success here, because some things have been extraordinarily successful. The distribution of antiretroviral drugs for HIV/AIDS has had a lot of success stories, but a lot of times you run into things where things are in silos, and too many people are doing the wrong things. I'm my greatest example of that, because I've spent a lot of time in Haiti, first for HIV/AIDS, and then I was there after the quake and for covering cholera, is that there's so many groups that are trying to do so many things, and they're not competing in a situation that's very, very chaotic often, and you just see the pathos of how many lives are not saved that could be saved because there's not communication on a scale that works. And I don't have a solution to that, but that's an example of things that don't work. I think that an example of something that does work is getting information out in a situation where people are paying attention. One of the things about target learned in my years as a journalist is that when people think something affects them, that they pay a lot of attention, and that's a critical moment for anybody who is dealing with communicating with the public, is to realize that people want information, they want it quickly. And in terms of learning how to do that, I would advise that people study people who communicate with the public about technical issues very successfully. And I would raise as an example, two examples of that. Deborah Hersman, who was the head of the National Transportation Safety Board in the United States, and even though in the movie Sully that agency is portrayed very badly, she was spectacular at conveying complicated information to the public. Another one is Dr. Anthony Fauci, head of the National Institute on Allergy and Infectious Disease. He's fantastic at talking to anybody who wants to listen. He never talks down to his audience. He always explains the science. So I think there are individuals who do it very well. As with so many other things, you can watch them and learn to do it better. That doesn't mean you can watch a brilliant tennis player and become a brilliant tennis player yourself, but you can watch communicators, and you may never be as good as they are, but you can try to be.
Excellent. Thank you so much. And Susan, how can governments and NGOs compete effectively for social marketing space from a health perspective, such as alcohol, when up against big industry with social marketing money that eclipse the budgets of government, health authorities, and NGOs? Would you support, for example, limiting alcohol and pharma industry marketing to the public like we did with tobacco?
Yeah, an excellent question. And I think, when you look at that industry, they're always going to outgun the public health experts in this area. So I think importantly, kind of really being able to pick your battle there. Where and how can you get the most leverage for your dollar? And I think advocacy around structural issues like reduction of their ability to market publicly, et cetera, taxes, labeling information, those are great ways to kind of go up against the big guns, so to speak. And I also wouldn't underestimate the power of a really well-organized, coordinated movement to affect change. We've seen things like Mothers Against Drunk Driving. There's a lot of ways to build movements, and this goes back to that idea of we're living in a very different world than we were 20 years ago, and the ability to engage people through the digital media space is phenomenal, and that can create a lot of change without a lot of money. I think the other interesting aspect of this is that the whole area of health communication and social marketing space has grown tremendously, and there are a lot more players in this area. So almost the strength of all of us out there doing this is also one way to kind of bring a little bit more power against the big industry folks. And there's just a lot more capacity and resource than there used to be on our side. And I think lastly, one thing in the health communication space that we've done as the field has evolved is we also borrow and learn from the techniques of the big marketing companies that are supporting these industries. And so we need to ensure that our health communication programs really are using the best, most impactful techniques and ensuring the effectiveness of what we're doing so that the dollars that we are spending are being spent effectively. And I think, one example of this is right now the UN SDGs are being supported by a big advertising company from Madison Avenue. And they're really kind of bringing a whole new perspective to the public health agenda and really putting it out there in terms that compete with, mainstream media. So I think there's a lot of energy in this space, and there's a lot more private sector engagement in doing the right thing that goes beyond corporate sector responsibility. So, there are ways to combat, the big pockets, the deep pockets of these industries.
Terrific. Thank you so much. And Firdaus, encouraging people to practice good hand-washing behavior and use toilets hygienically continue to prove challenging around the world. What can we learn from activities?
Well, thank you for the question. I'm going to actually challenge the premise of the question because I don't know why it has proved challenging around the world. It shouldn't be. I think that behavior change communication sometimes fails, though, because we attempt to coerce people into changing their behavior. If you think of many of the domestic violence campaigns around the world, and I have worked on these issues extensively, you will see quite often the image of a battered woman, and it'll portray the woman and say basically, thou shalt not do this. I don't think that works. I think that what happens in that situation is that you further stigmatize the woman, you propagate the idea of battering a woman, and you don't do anything to address the first behavior we need to change, and that is not the woman, but the man who's doing the attacking. So I think that if we were to learn from practices, we need to understand that people need to internalize the message. They need to come to the decision themselves that they need to change their behavior. We cannot impose it externally, no matter what it is, whether it's hand washing or something else. We cannot impose a decision a change of behavior from outside. We have to get the person to come to their own conclusion that they need to change their behavior. If you look at much of my work, I use animation and I use humor to get my point across, even on very serious issues. And I've learned over the years that animation has a lot of advantages. It gives you a suspension of your disbelief system and allows you to accept what the message is and internalize it much more easier. And humor is because it's non-coercive and non-threatening and is there simply to bring you to the end of the spot that I've created, which gives you the message that I want you to internalize.
Wonderful. Thank you so much. And Susan, what are some of the most effective strategies to use social media to engage patients in their own care and connect them to individual evidence-based medicine? How do these strategies differ in places where internet access is less reliable?
Well, I think there's a lot of different ways in which you can use the digital media to connect potential clientele with services and their access to care. One example to talk a little bit about is in South Africa, where we have been working on HIV and voluntary male circumcision and developed an app that helped consumers. Provided information to consumers, but also built in a GPS, was built on a GPS system that allowed them to find specific services in their sites. In other cases, I'm sure everybody's read about services, SMS services, and other smartphone apps to increase retention for ART treatment. Another thing that we did in South Africa, which was actually really a lot of fun, is we had supported a number of different serial TV series across a number of years looking at HIV, and one of these was called Intersections, and it tied together different episodes and different people dealing with, issues, stigma, all sorts of things around HIV. And what was happening as that series was being broadcast is that we had an associated Facebook site, and while the show was airing, people were talking about the show on the Facebook site. So it was a really interactive structure for both what was kind of being broadcast, but then letting the audience take what they were thinking and how they were reacting to that and sharing it with others. And, the number of people that were getting on and posting, and what they were posting was just really phenomenal and resonating with what was being said in the show. So they'd talk about a character and say, I am throwing out my black book. I'm not going to keep these phone numbers around. I'm not going to be like so-and-so. And so you get them really embracing and internalizing, as our last speaker just said, that message to themselves, really resonating with what was being showed in the program, and using the social media space to really amplify that a bit more. We also have an entertainment education program in Nigeria, and one of the things we've done there is a music video and song around family planning. And that's been out over social media, and it's got over 2.5 million hits now.
Fantastic. Thank you so much, Susan. And Charlotte, how does health communication differ for children and adults?
Well, it's an interesting question, and I think in many ways my response kind of echoes much of what Firdaus was saying in his comments, because what works for kids is often the same thing that works for adults. You want message to be clear. In the case of kids, you want it to be developmentally appropriate, relevant to their life experience. You want it to be engaging rather than preachy. But with children, really, they learn best when you show them what to do rather than what not to do. And it's modeling the correct behavior is one of the best ways to normalize it. And when you do that using popular characters or celebrities, with engaging content that is fun and appealing, this is what is particularly effective. In general, it's really best to show what to do rather than what not to do, because really what we've found, and this is kind of echoing what others have said earlier, is that when you use media to tell children, don't do this, don't play with matches, that message becomes very salient, and it can actually prompt the child to engage in the very behavior that you're trying to counter. So you're basically teaching them how to play with matches. And so it's just so much better to have a positive orientation and to make the message be something that's really relevant to the child's environment. And, if you want to teach hand washing, you want to make sure that you're using, you're placing it within a context that is meaningful for the kids. And so if children are in a place where they don't have indoor plumbing, you don't want to show sinks and faucets and equipment that's not part of the child's reality. You want to present ways of washing that match that child's experiences. And I think this is just the same kind of thing over and over again. If you want to promote good nutrition, you need to be pointing to foods that are available locally, that aren't too expensive, that are accessible. And I think these kinds of principles, clear, positive messages that are culturally relevant, that are engaging, that aren't didactic, that, really those can emerge when you're having advisors from a given locale that are intimately involved in the process. They're devising what the message should be, and they're reviewing the content and really involved in developing it. All of those come together to really make for the best kind of communication to children. And I think many of those principles also apply to any kind of health communication, whatever the age of the target population.
Wonderful. Thank you so much. And Bob, how can scientists communicate and deliver information to non-science individuals about health crises?
I'm sorry. Could you repeat that?
How can scientists communicate and deliver information to non-science individuals about health crises? Can you hear me okay?
Yeah, I can hear you fine. I think that what they have, it again gets back to this thing, and we're repeating a lot of things, but you have to understand your audience and what they understand. You never seem like you're talking down to them, and you don't denigrate their fears. People are going to be afraid, and that's why they're paying attention to you. And the worst thing you can possibly do during a crisis is to say that you shouldn't be afraid, because they are afraid. And if you say that, you're immediately going to turn them off, and they're going to go to the internet for some crazy theory about what's going on instead of listening to you about the best possible facts. And of course, you put it in the light of the best knowledge. And by far, the most important thing is to say what you don't know. Is to say that we're working on this problem as fast as we can, but there are still some things we don't understand, and we will let you know as soon as we do understand them. And I think that is a very reassuring message, much more than any kind of false reassurance. And of course, the worst possible thing you can ever do is to lie, because once you're caught up in false reassurance, you've lost your audience, and they're back onto some crazy theory that they're going to get from the internet or elsewhere.
Perfect. Thank you so much. And Firdaus, how do you embrace and practice culturally and linguistically appropriate services effectively and routinely using social media messaging?
Well, thank you. That's a very important and difficult question, and something I spend a great deal of time with, as you can imagine, since my work is now in 169 language versions. So the first thing I would say is that we never translate anything. I'm dealing with the linguistic part first. We don't translate anything. What we do is rewrite the script in every single language. So even when we have something, for example, in 8 versions of English, the South African English or the Indian English or the Canadian English will not only sound different, but in some cases actually use different words, even though we're communicating in English, so that we make it as local and culturally, linguistically and culturally relevant as possible. The second thing is that you have to, we have an advantage when we use animation because it's easy to sync. It's much easier to sync than live action. And it gives you a suspension of your disbelief system, as I mentioned before. So if you have a ethnic person irrelevant to a certain subject or to a certain audience, it becomes more difficult for them to understand and to accept that person speaking and usually out of sync with them. So, for example, if you have a black person speaking in Chinese in China, it is more difficult to get your message across than if you have an animated character speaking Chinese in China, because animation gives you the sense that that person is not real, and therefore you're more accepting of the person speaking that language. I do believe, though, we can communicate throughout the world using basic knowledge and basic communication skills. We have been able to communicate in my work despite the many barriers that separate us as human beings, and that includes languages and cultures. So, for example, my HIV/AIDS campaign, which you can see on the Vimeo channel, currently exists in 45 languages, and about 70% of the world's population can see it in their own language. It is 3 funny animated condoms. You might imagine that it was played in Western countries, which it was, like in Canada and Holland, but it was played in multicultural countries like India and South Africa. And here's the kicker. It was on national television in Iran, in very conservative countries. So how do you get 3 funny animated condoms on Iranian national television? Well, you make them funny, you make them animated, you make them talk. They look like condoms, yet you know that when you see them, then they're not real. So that's how you get around the various cultural barriers. This is a subject that I could talk on for a very long time. I'll leave it there.
Excellent. Thank you, Firdaus. And Charlotte, what are the best practices for addressing cultural differences while developing and implementing a social marketing program that targets minority populations? Well, I think, a lot of the comments that we've been making apply to this as well, but I think, any media health communication needs to have people from a target population involved in the development process. And so it's really essential to engage in a process that begins by bringing people together from the target audience. And in the case, if it's a minority population, making sure it's people from that population that are there to help determine the messages and show how they can best be modeled. And this is a little bit about what's already been discussed in terms of language, not translating, but rewriting. And that same principle applies both not only in terms of the language, but in the content itself. And that can best happen when you have people from the population involved. And again, with children, as with adults, they are going to learn best when the content that they're exposed to matches their own experience. So you want to make sure that the environment that's depicted, the activities, the people, are like the children that are being targeted for the messages. And some of this sounds, in many ways it sounds very obvious, and, as you start to articulate it, just seems like why isn't that happening? Why don't people do it? But it can be more complicated to actually enact than to talk about enacting. I mean, it's complicated to bring people together and make sure that everybody is really involved in the process. But it's doable, and I think essential in if you're really serious about meeting the needs of a given population. And I think
the lesson really is to involve the population in the whole process, from the very beginning to the concept to really looking at the prototypes and being able to review the content as it's being developed, and then actually also having people involved once you look at research and gather data about impact, to have people from the population involved in interpreting that data. All of that is important.
Great. Thank you so much, Charlotte. And a question for Firdaus. Do you have teams that handle the communication conversions in lieu of translation, or do you outsource that to a specific type of resource?
We outsource that around the world. So what we would do is we would have teams of people who are adapting things. I'll give you an example. I just came back from Ecuador, where I'm working on a some animation for teenagers concerning Colombian refugee teenagers in Ecuador. And not just are we translating or at least adapting, rewriting the script in Spanish, but in fact I've put together a youth advisory committee composed of youth of both Ecuadorians and Colombians in Ecuador, but teenagers, to put the scripts into very local vernacular, into very local language, so that they will help me devise the entire language approach to it and make sure that the wording is appropriate for their age demographic in that country. That's just one example.
Great. And another question for you, Curtis. What is the difference between health marketing programs in developing countries versus developed countries? How is the implementation different?
Well, I don't think it is that different. I think nowadays we are becoming much more of a global society. We are breaking down through modern communications the barriers that exist, the tribes and ethnicities, geographies and borders, and indeed the rich and the poor. And the best example of that is the universality of mobile phones or cell phones that's happening around the world. There are now more mobile phones than there are people on the planet. Of course, they're not uniformly distributed around the world, and many countries still have a long way to go in terms of communications. But I think we're getting there. Every year, more and more people are able to communicate directly, personally, in-house. The importance of this cannot be overstressed. To give an example, when the Ebola crisis happened, I created an animated short that we finally did in 17 West African languages. And to the best of my knowledge, it became the most watched visual media in West Africa to try and contain the spread of Ebola while it was happening about 18 months ago. And the way it was most watched in the country of Guinea, where the current Ebola crisis had erupted, was by passing it from cell phone to cell phone to cell phone. So it got into many places where it would not have gotten in any other way. And I think that that's a good example now of how we might think that other countries are now catching up, leapfrogging in some cases, their technology, and we can use that technology locally to make a difference on these kinds of issues. So I think that the differences between developed countries and developing countries is quickly evaporating.
Great. Thank you so much. And Charlotte, what are some of the successes and failures in children's media? And if you could, what advice would you give to yourself a decade ago?
Oh, gosh. Well, I think, in terms of success and failure, I tend to not think in terms of failure. I tend to try to look at what are the most successful programs and how can you build from those. And I think part of that orientation is coming from, as a researcher, in many ways, if you're looking at everything with a research orientation, it really allows you to try things and see what works and take risks. And then failure is not really failure, it's really a learning. And the biggest failure then is to not build from the learning that you've gained from trying out different things and really putting them to the test. I think in terms of kind of the most successful media campaigns, those are, these are just, I'm sort of repeating what others have said, but they really are the ones that involve local teams in the creation of the messages and that are the most culturally relevant and engaging and fun. And I think there are so many examples of this now that emerge. We're working with a wonderful team in Ethiopia that has a program called Sai Loves Learning. It's a puppet program for young children. It's having a huge effect. They just got funding from USAID fairly recently to do a health education program, and the research is really showing that it has a big effect. And I think partly a part of the reason it's having so much success is that it's been developed locally by a local team who's developed those scripts and the messaging, and it's really moving forward in a wonderful way. And I think we also are working on a project in Haiti, and I think when I look back at that, like, what advice have I learned from, say, a decade ago that we can apply to this new programming? It's called Le Coup que Joue in Haiti. I think one of the things that we've really gotten better at is we've learned the value of collaboration. And what once more is that with newer technologies, we are even better able to collaborate in the past than we were in the past. And I think we don't need to keep reinventing the wheel. We can look at what successes have been happening over the years and build on those successes. And I think if we really work together, none of us have all the answers, but when we work together and cherish each other's expertise, we can make a true and lasting difference. And I think never before have we had the tools that we have now to enable such collaboration. And so I think the big lesson is kind of how to work together and really use the expertise of all so that we're really building the best possible campaigns for the future and the ones that really speak most directly to the needs of a given population and do it in a way that's relevant and engaging, and that will ultimately have the biggest effect.
Fantastic. Thank you, Charlotte. And Bob, how can the media improve their delivery about current health concerns and considerations?
Well, the media is a plural word, and I think everybody on this call is involved in media in one way or another. And one of the biggest problems is that the media are blamed for things when, in fact, of course, there's so many actors doing different things of varying degrees of responsibility, and we can see that in the presidential campaign. We can see it in public health. So one of the things about asking for improvements in the media is you really have to be, as with so many other things, you were talking about knowing your target audience, working with your target audience. You have to identify the media that might be helpful to what you're trying to accomplish and get to know them. It is a two-way street, but the two-way street is not just getting to know a target audience if you are trying to, say, change behavior. It's getting to know the media that you want to deliver your message if you're using some kind of established media, such as an internet, whether it's a television network, a newspaper, an internet site, or just a cell phone message. You need to understand, you need to have a relationship with the people that are putting out the information and try to work together to get what you agree will be the most mutually beneficial result.
Excellent. Thank you. And another question for you, Bob. How can organizations and NGOs better use communication to target specific audiences and market their cause?
Well, I think we've had a lot of discussion on this call about targeting audiences, and I think that is exactly the point, that people are looking to do that all the time. The Internet, Google knows how to target its audience. Facebook knows how to target its audience. These algorithms have been developed exquisitely, and it's only going to get better and better. They can do it for advertising, but people who are looking to deliver a message can get it to very specific people, often at a very low price by working with the companies that have done this. You can't look at Facebook as your enemy because there's so many billions of people on Facebook. You've got to work with that kind of organization to see how your message can be fit in, at what place and at what cost, and who will see it. This is extraordinarily elegant right now, and as I said, it's only improving.
Wonderful, thank you. And Susan, what is an example of a health communications program that was expected to work but ultimately was effective? What should have been done differently?
That's a bit hard for me to respond to directly, but I think we've touched on a lot of the issues that make a communication campaign effective. And I think as one speaker said, if there's a failure, it's the failure of learning from what happened. And I think this kind of brings out the importance of really not only being careful in your construction of the program with all the ideas that have been shared already today, but building in a system in and around that program that provides the monitoring and evaluation so you understand what is happening as a result of the program. Is it having the effect you want? One example I think that comes up a lot is a program that perhaps wasn't as effective as people thought it could or should be is, the Just Say No and the DARE program for drug prevention in the U.S. I don't know enough about it myself to say exactly what went wrong, but I would, ask the questions. How much research was done? How was the audience involved in developing that program? How was it tracked to understand how messaging was being understood? And again, all of those principles that have been shared with others. I would also add one thing that hasn't been brought up so much on the call is the idea of really ensuring that health communication programming is part of a program from the outset, that it's an explicit component of whatever the broader agenda is, and to see that as part and parcel of the program rather than as an afterthought of, let's do communication to support this program. And in doing so, looking at health communication and how it connects to the broader program or services it's supporting so that the entire program is seen as holistic and not piecemeal, and that direct connection with services, which makes for a stronger, more impactful program.
Great. Thank you, Susan. And do you have additional thoughts on this question about an example of a health communications program for children that was expected to work but was not effective, and looking back, what could have been done differently?
I think, again, it's a little hard to talk about what it is and isn't effective. I think, there's the research that's been done on different programs, I think, is still kind of in nascent stages. But I think that, again, I like to think in terms of best practices, but I think that there are times where you have to look at resource issues of kind of, opportunity costs and what is being invested in a given media program versus how that kind of funding could be used in another way. And I think that the most successful programs, of course, we've talked a lot about those ingredients in terms of making sure that they're culturally relevant. I think there have been some programs that, particularly in terms of like nutrition and even hand washing and these kinds of programs, when they are presenting content that doesn't match the child's reality, they really are not very effective in moving the needle because the children really don't see it as relevant to their life, and it doesn't model any kind of change. And I think that we do have research that shows that the closer the content is to the child's own experience, the more effective the communication is. And it's particularly true when the communication is very simple and the instructions are, easy to follow.
Wonderful, thank you. Question for Firdaus: how do you decide what topic to focus on in particular countries? And then also an additional question: do you have experience with mental health campaigns, and what are the challenges and solutions in this field?
Okay, thanks for those questions. Can I actually just add a little bit to what was the previous question, if I might just start with that very briefly? I think the Ebola crisis is a good example where the international community in general reacted very, very slowly, and when we did react with inappropriate messaging systems. And I was one of those pounding the table when the Ebola crisis first appeared, and Médecins Sans Frontières had raised the alarm, because what the international community did was basically set up quarantine units and send doctors and nurses from around the world, and we spent hundreds of millions of dollars treating people after they contracted Ebola, and spent a fraction of the amount on communicating how to prevent getting infected in the first place. And I think that when we did try and do that, we were creating brochures and pamphlets, and I stood up in a meeting and said, but you have to understand that the literacy rate in these villages in Africa is very small. It's very low, in some cases less than 20%. And even if they were to read and write, they probably can't do it in the national language that you're using, which is usually either English or French in West Africa. So I think that we have not learned all the lessons that need to be learned, that we still make mistakes in creating these communications programs, and that we still have a long way to go in developing the expertise, and more importantly, in sharing the expertise amongst ourselves. The other two questions that you asked, do I have time? Because I noticed that we're coming up to the 1 hour. So would you want me to answer them?
Yes, that would be wonderful. You have a few short thoughts regarding how you decide what topics to focus on in particular countries, and also challenges and solutions with mental health campaigns.
Okay. The first question is easily answered. It's usually a difficult subject. It's a subject that requires media. It's a subject where we require individual behavior change to occur. I have a whole list of criteria that I usually go through. Sometimes organizations and institutions ask me to create something, and sometimes in the case of huge global campaigns, I have the idea myself that this is something that we need to tackle, for example, domestic and sexual violence around the world, which nobody else wanted to touch with a 10-foot barge pole. Now, in terms of mental health, I have done some work, and if you go online, you will see a live action video that I created on caregivers to people with dementia themselves, taking care of themselves. Between the two versions that we did in Canada, which was English and French, we have over 250,000 views so far. I think that mental health is an area that really requires a huge amount of work, especially as we have an aging population in the world. And this is something that needs a lot more attention than we've been able to give it so far. I'll stop there.
Wonderful. Thank you so much, Firdaus, and thank you to all of our phenomenal panelists. This brings us to the end of today's webinar. Thank you again to everyone for fantastic questions from the audience, as well as phenomenal answers from our panelists. Thank you.
Thank you.
Jennifer.
Thank you.